Just keep pressing and go to the next one. Sorry, yeah, that'll be done. Yeah. All right, and are you gonna feel? Okay, so you want my correct application, please, and no, sure, I'm there, okay. This is. Look pretty good. All right. It's smaller.
No, let's make sure you're. Dr. Sommer asked for single and pill lines.
Push this down, so I should put it out here, so the next person will have. Hello, everyone. Good morning. We have a great panel of speakers today. Our speakers today are Dr. Polito, Dr. Stewart, Dr. Vignosi. Our program is underwritten by an educational grant for OSC Medical Center graduate medical education. A disclosure statement has been signed, is on file in the GME office. Just a brief intro on everyone. Dr. Polito is a board certified pulmonary and critical care physician practicing here at OSU, who went to medical school at Lee Brandon. Completed IM residency at OSU and subsequently completed fellowship in pulmonary disease and critical care at Brooke Army Medical Center in San Antonio, Texas. He's a veteran of the United States Air Force, having served 7 years in Texas and Alaska. He was the sole pulmonary critical care medicine provider for the United States Air Force in Alaska and served as the medical director for the ICU and Pulmonary Disease Clinic for the 673rd Healthcare Operations Squadron in Anchorage. He joined OSU after being honorably discharged in 2024. Next, we have Dr. Stewart. He's an intensivist at St. Francis Hospital who recently joined there with the cardiac critical care team. He went to medical school at KCUMB and completed his residency in emergency medicine at Darnell Army Medical Center and fellowship in critical care at the University of Washington. Prior to joining St. Francis, he served with the U.S. Army and as faculty at the University of Washington. His medical background also includes experience in GME and as an emergency and flight physician. He is board certified in emergency medicine and critical care. And then we have Dr. Vignosi. He's a critical care anesthesiologist with over 47 years of experience. He went to medical school in Cairo and spent time training in Germany. He's highly regarded in his field, particularly with ECMO, and has been instrumental in developing and advancing multiple MCS programs throughout the nation. He's currently practicing here at St. Francis Hospital, and this program has been vital in providing accessible care for patients who previously had limited options in our region. We're lucky to have him in town. The Cloud CME activity code for today's grand rounds is 3,228. We're privileged to have these three physicians here with us and have a lot to learn from their experience. Please join me in giving them a warm welcome.
Good morning, everybody. Thank you for being here. So our presentation today is going to be divided into 3 parts. We're going to talk about the indications, contraindications for ECMO, BD, and BA, and we're going to move on to the actual process of cannulation and talk about pitfalls and complications. So we're going to start with indications, contraindications, and sense. I like to start all my presentations with clinical cases, and this is based on one of my experiences. So I'm going to take it back in time to October of 2021. SARS coronavirus 2 Delta is ravaging the population. Absolutely, COVID is in full swing. You were the sole intensivist at a community hospital in Alaska, and a transport coordinator calls requesting patient admission from a rural hospital 8 hours away. So this is a 35-year-old male with 10 days of cough, dyspnea, vomiting, diarrhea, GI symptoms, and just feeling not very good. He's otherwise healthy, has no past medical history, surgical history, or otherwise occasionally drinks alcohol with his wife. His vital signs are as follows. Hemodynamically, he is tachycardic, he is severely tachypneic, he's hypoxemic despite aggressive oxygen supplementation with a non-rebreather. His BMI is relatively normal. He has leukocytosis, and you can see that he has manifestations of volume depletion in addition to an achyapnea. He is positive for COVID-19 and flu negative. So you get a call from the transfer coordinator at said rural hospital. Patient decompensated and required intubation prior to transfer. He's being life flighted to your facility. The physician who's taking care of him lets you know that these are the IMV settings that they chose on their PB980 before sending him your way. They set him on a respiratory of 18 and a rested tidal volume of 620 cc's, an I time of 1.2, FI of 2 of 100%, of course, a PEEP of 5. His ABG with those settings demonstrates severe metabolic or severe respiratory acidemia with pH CO2 of 78, pH of 7.14, and he is still hypoxemic. You, being the astute intensivist, asked him about his ventilatory parameters and how he is tolerating this mode of IMV. And unfortunately, his peak airway pressures are quite high. His mean airway pressure is quite high. They do not know how to measure a plateau pressure, dynamic or static pressures. You asked to speak with the treatment team to give them recommendations regarding their IMV strategy. They're uncomfortable with your changes, so they say they're just going to send them to you. That is absolutely my experience very commonly. Patient arrives and he is hemodynamically unstable. He is receiving a vasopressor already. He remains hypotensive, tachycardic, and hypoxemic. He rolls into your facility paralyzed, so that is one thing, but you immediately, again, very astute physician, order chest film and ABG. His pH is worse, his PCO2 is severely elevated, and his hypoxemia is legitimate. You continue to titrate vasopressors and start standard of care at the time for COVID-19 severe disease, and your chest film is as follows. So again, being very familiar with ARDSNet, you immediately implement the protocol that you are very familiar with, make the following changes. So you aggressively titrate his mid-ventilation. You adjust his flow rate with ACVC, not a hybrid mode, and you reduce his tidal volume to 4 cc's per kg for his body weight, set his peak to 18 and his FI2 to 100%. His peak airway pressures and plateau pressures are still outside of parameters. His mean airway pressures are high. His dynamic and static compliance are very poor. He is mildly air trapping, thanks to your continuous paralytic infusion. Again, following ARDSNet guidelines, because his pH is quite low, below goal, you administer bicarb. You start an index infusion for ventilator synchrony, and his pH improves slightly. You pronate the patient, again, for the procedure trial results and ARDSNet guidelines, and you get a mild improvement in his ventilatory respiratory parameters. However, his pH still remains quite low. His PaCO2 is unmeasurable, and he is modestly improved in terms of hypoxemia. So here is his ABG after another 30 minutes of your interventions. pH is getting worse, PaCO2 is getting worse, PO2 is suffering, and his SO2 is 81%. Again, this is a 35-year-old otherwise healthy male. So the patient's getting worse, worsening hemodynamics. He's requiring 2 vasopressors now in addition to corticosteroids. Increasing his ventilation incurs worsening airway pressures. He is trapping air despite a continuous neuromuscular junction blockade. He started concentrated bicarb drip to try to compensate for his severe respiratory acidemia and your inability to clear carbon dioxide. You do not have inhaled nitric oxide. When you ask your hospital whether we have an INOMAX, they ask you what that is. You do not have any nebulized epoprostenol or agents such as Polito or Flowlan. And the patient's 30-year-old wife says that he is otherwise a productive member of society, has a job, he has a young child at home, and his entire family is here begging you to do everything you possibly can. What do? All for help. So extracorporeal membrane oxygenation or ECMO. So modes and configurations. I think most of us are familiar with this at this point, but essentially we have 2 modes and then multiple hybrid modes in addition to that. So for respiratory failure, we have veno-venous ECMO, cardiac or refractory cardiogenic shock, we have venous arterial ECMO, and then hybrid modes depending on the needs of the patient as they recover their organ function. And we will talk more about the configurations, et cetera, as we go on. We're going to focus on indications, contraindications. So what is VV ECMO? With the veno-venous strategy, we are withdrawing blood via a large peripheral vein of the femoral or IJ, typically via centrifugal pump. Venous blood passes through a filter and membrane oxygenator, and fresh gas flow is used to sweep carbon dioxide out of the system and add oxygen, which is then returned to the right side of the heart via another large peripheral vein, femoral or IJ, either via two separate cannulas or a dual lumen single cannula. So what does this effectively do? It effectively replaces the function of the sick lung. Typically with a severely ill respiratory failure patient, we are utilizing their sick lungs and flogging them with a ventilator to continue to perform their function. This allows us to rest the lungs and bypass the function with the circuit. So just kind of a quick overview of the circuit components. We have the flow meter, we have the actual cardio health, and then we have our filter, and we'll go into more detail. I'm sure Dr. Vanyosi will talk more about the actual physical components of the circuit, but it's quite a device, quite a configuration. VA ECMO, what is it? So with VA ECMO, we are withdrawing blood via a large peripheral vein, again, venous blood, via centrifugal pump, same way, fresh gas flow again. Air oxygen blender eliminates carbon dioxide and adds oxygen to the blood, which is then returned to the proximal aorta via the superficial femoral artery. So essentially, we're passing a cannula into the arterial system and threading it up toward the heart. Bypasses lungs and heart, returns blood to the proximal aorta as subflow rates, applying to great vessels in a patient who has severe cardiogenic shock to the head and upper extremities and lower body with oxygen. So again, it does not rely, it bypasses the function of sick organs, differing from our typical mechanical circulatory support. It doesn't rely on the ability of the heart to pump or lungs to extract oxygen or perform gas exchange essentially, and oftentimes is used in conjunction with other assist devices, such as an reduced LV volume. So again, kind of a quick overview, VA ECMO, slightly different, and then the return cannulas pass through the aorta up toward the heart. So VA ECMO, very quickly, with VA ECMO or arterial and venous ECMO, we have a limb that is also supplying oxygenated and fresh blood to the right side of the heart in addition to the left. So we're eliminating carbon dioxide, adding oxygen, which is returned to the SFA and peripheral vein via two separate cannulae. So this is useful in cardiogenic shock patients in whom their recovery function and pushing their mixing cloud distally in the aorta so that we can then provide oxygen to the great vessels and prevent a condition called heart embolism, which we will talk more about later. So again, as we have recovery via ECMO becomes more useful. So indications for ECMO. Generally, this is indicated for severe acute reversible cardiac and respiratory failure that failed aggressive conventional management or is likely to fail aggressive conventional management. VV ECMO, again, for severe hypoxemic respiratory failure, our guidelines typically state for patients with a P to F that is severely reduced, so severe ARDS typically, despite maximal medical therapy and a trial of prone positioning. Hypercarbic respiratory failure, patients with a pH that is severely reduced despite aggressive INV with a total respiratory rate greater than 35 and a plateau pressure that is still at our goal. VA ECMO, cardiogenic shock, and we also have ECPR, or essentially cannulating a patient who has experienced cardiopulmonary arrest for the purpose of resuscitation in a highly selected patient, which we'll talk more about. So VV ECMO indications, really any and all causes of hypoxemic or hypercarbic respiratory failure, again, that are potentially reversible. Prototypically ARDS, so related to sepsis, infection, burns, essentially any cause of diffuse alveolar damage in ARDS, diffuse alveolar hemorrhage, patients with status epilepticus cannot be oxygenated or ventilated due to the nature of their disease, any kind of traumatic lung injury, so large BPF, talk a little bit more about that. essentially in a patient who we want to absolutely rest their lungs and as a bridge to transplant. So I worked at a CVI center for a while and we would cannulate patients in anticipation of allogeneic lung transplant. So for acute lung injury, essentially we're replacing the function of the lung, stopping injurious ventilatory modalities. Again, we are, without this intervention, we are utilizing a safe organ and potentially exposing it to ongoing barotrauma, volume trauma, alloy trauma, which could perpetuate the injury that led them to this state in the first place. For chronic lung pathology, again, replace lung function in anticipation of destination therapy, which would be lung transplant. Patient selection for VV ECMO, there really is no age limit. If you called around during COVID times, you would know nobody would tell you outright that your 75-year-old patient could not be a candidate for ECMO. But what it really comes down to is their functional status, the likelihood that they could be rehabilitated, recovered, and or transplanted. Would they be a candidate if they could not decannulate, if they could not survive? If the lung disease is end-stage or irreversible, again, patient would have to be a transplant candidate. They would otherwise have to satisfy those criteria. So patients with active cancer, for instance, that would not be a person that you would want to cannulate if you knew that their disease was not reversible. And the patient should otherwise be free of comorbid end-stage organ disease that would otherwise preclude rehabilitation or long-term survival. So we do have some guidance in selecting patients for VV ECMO. We have the RESP score, which can predict survival and kind of help us make that decision. I went ahead and plugged in my patient's parameters for his RESP score. You can see that he did have a favorable chance here. So when I called my team to cannulate him, this is some of the information that I used to justify that course of action. So that on MD Calc, you can just pull that up and pull it up on the internet and use that as a part of justification. You can see that the parameters age, whether they're immunocompromised, how long they have been intubated, the type of lung injury that they have, whether they have CNS dysfunction, another infection, and essentially, this takes into account whether you really provided standard of care and how they responded to it and kind of what they needed to get there. So were they severely acidemic? Did they require bicarb infusion? Did they have cardiac arrest? Are they severely hypercarbic? Are you meeting your ARDSNAP recommended respiratory parameters in terms of peak and plateau airway pressure? So for VV ECMO, contraindications relative. This is a very important one. The longer this patient has been in the state of diffuse alveolar damage, severe lung injury, the longer they've been intubated and mechanically ventilated, theoretically, we've perpetuated their lung injury that long. So the longer they're in this state, the less likely they are to recover and do well, more likely they are to enter a fibrotic state of lung disease and ultimately not be able to decannulate or be left in a state that requires lung transplant. So their survival is likely better the faster we get them on circuit. So patients in who they've been intubated for more than 7 days are less attractive as a candidate. Anybody who has active systemic hemorrhage or any kind of active bleeding dialysis, because again, in order to cannulate them, we'll need to anticoagulate them for the circuit. So anybody with a contraindication to anticoagulation, older age or poor functional status is what that should really be, with low rehabilitation potential. And of course, non-transplant candidacy in patients who otherwise have irrevocable lung disease. So moving on to VA ECMO, essentially any patient with refractory cardiogenic shock who otherwise would be a candidate for that type of support, similar to VV ECMO. Cardiogenic shock, systolic blood pressure less than 90 with low urine output and elevated lactate, low SpO2 despite low central venous oxygen saturation and AMS despite optimal medical therapy. So essentially you try, you're not clearing lactate, their response to medical therapy is inadequate. Patients with cardiogenic shock and fluid resuscitation, inotropic therapy, and potentially lesser forms of mechanical circulatory support continue to fail to clear lactate or improve their hemodynamics and manifest continued end organ dysfunction. So anything that leads to cardiogenic shock in somebody who's otherwise a candidate. So pulmonary embolism, MI, myocarditis, So this is something that the other panelists will go into again, but essentially, our thought is that for patients who present with refractory cardiogenic shock, this is an intervention that we should be thinking about sooner rather than later. The sooner we can select these patients and get them started on the pathway, or at least alert the ECMO team that they are potential candidates, the better. So ideally within 6 hours of onset of cardiogenic shock before they develop florid multisystem organ failure. So extracorporeal life support organization, or ELSO registry, so essentially there are factors associated with greater and lesser likelihood of survival with VA ECMO. Again, they kind of line up with what you would expect. Patients who are severely comorbid or older, patients who are rested, or those who are farther along in the disease process with cardiogenic shock, specifically if they've already manifested multisystem organ failure. The later you arrive to this patient, the less likely they are to survive. Of course, patients who are younger, patients who are non-obese, patients who otherwise have more favorable ventilatory parameters, they're more likely to survive. So how do we determine who is a candidate for VA ECMO in addition to the aforementioned parameters? We also have something called the SAVE score, or survival after veno-arterial ECMO score. And again, this is something that is accessible to anybody who has an internet connection, anybody who has an ECAL. You just pull this up and type it in. So when you're considering this is something that you would do in order to help the ECMO team make a decision about whether this is a candidate for therapy. So here's an example of what our graph looks like. Plug and play, pretty easy. So the last thing I want to talk about is ECPR. I don't know how often you guys are doing this. We would do this occasionally in San Antonio for highly selected patients when we were very ideally positioned, but essentially extracorporeal resuscitation. This is a patient who's experienced cardiac arrest. You determine very quickly that there is somebody who you would have providing veno-arterial ECMO for while you're sorting out the etiology of their arrest. So if you have a 40-year-old individual who just has sudden cardiac death, for instance, and you're very early in the resuscitation process, witness arrest, patients who are generally younger, and individuals who receive ACLS efforts more rapidly, patients who have other favorable indicators of potentially achieving ROSC, so those with an end-tidal CO2 that's greater, lower arrest times, and importantly, known severe valvular insufficiency. If you recollect the positioning of the arterial cannula, if you have severe AI, it's going to be a problem as you're jetting blood back toward the heart. And of course, you would need to be sure that the patient, that this would be in line with the patient's wishes for what you knew about the patient or what their family is telling you. There's really no optimal time that's been established, but generally the sooner the better. Essentially, if you are very well positioned, if this is a patient who has been receiving ACLS for 45 minutes and you're calling in an ECMO team from an hour away, it's probably not going to end well. Contraindications to VA ECMO. In those individuals in whom cardiac recovery is unlikely, or again, they would not be a candidate for destination therapy or a transplant, and destination therapy could also be something like a ventricular assist device. Individuals who have poor functional capacity, or again, low rehabilitation potential, or otherwise comorbidities that limit their life expectancy. Patients in whom, from a practical standpoint, cannulation would be difficult, severe peripheral arterial occlusive disease, those with known aortic insufficiency, obviously anybody with active acute aortic syndromes, aortic pathology, and any kind of incapacitating CNS injury that would again preclude rehabilitation. Hopefully that was within 15 minutes. Questions? Yes, sir.
You mentioned one of the contraindications obviously being somebody who is bleeding in some form or fashion. I know that like diffuse alveolar hemorrhage can sometimes lead to ERDS. Where does that fall on the spectrum of contraindication?
If they have alveolitis or a capillaritis causing diffuse alveolar hemorrhage, I wouldn't necessarily say that that's nothing. If they have like a tracheoinoma fistula or something like that that's causing hemoptysis, that's different. So it depends on the etiology, because DAH is technically an indication for, for somebody who's presenting with essentially lungs that are unable for gas exchange. So that, if you have a true capillaritis, pulmonary capillaritis, you're giving them, you're crushing them with corticosteroids, and you're hopefully arresting that process too. So I would not exclude that patient. I would, obviously have a multidisciplinary discussion and talk to the family about that. But if it was a young person who had that problem, I would still consider that. Good question. Anybody else? Yes, ma'am.
How quickly are you identifying patients that need to be transferred? Like, I know that you and I had a case where we had an asthmatic that was intubated by EMS that was fairly young. And I know that we also had that pulmonary hypertension case. So if we have someone where we intubate and they're not doing well and they're fairly young and otherwise don't meet contraindications, should we be calling you guys to come and evaluate them before we send them upstairs? I know transfer out of the ER is a little quicker.
If it's a cardiogenic shock case, you'll engage with us in cardiology and we will help make that decision. We effectively have established our own process with our physicians from St. Francis about whether they have kind of a recalcitrant cardiogenic shock picture. And we are looking to transfer them sooner rather than later if they're failing conventional therapy. But in a highly selected patient from the ER, but I would still engage our teams to help make that decision. And for VV, these are people who are going to be in our ICU, and pretty quickly, like the case presentation that I had, for instance, I called my team in San Antonio within an hour of the guy being there, because he arrived to me profoundly hypercarbic. I knew I wasn't going to be able to clear CO2. I knew I was going to be dependent on bicarb infusion and just sitting there pushing bicarb at his bedside. I needed the circuit to remove CO2. So I just knew that I wouldn't be able to do that. So sooner is better than later, but still you should at least attempt conventional therapy. And again, I don't know if we're going to get into the weeds about like pulmonary embolism, et cetera, but yeah, multidisciplinary discussion. So, Dr. Baniotti.
But this, only 15 minutes, so I try to cut it. Morning, everybody, and thank you for having us here. It's a great opportunity to come here, to be with you here today and to talk about the cannulation. Okay. That's my disclosure slide. I'm going to go quickly on that, and that's my objective today for my presentation, to identify access for PAV ECMO, to recognize difference between surgical and peripheral cannulation, describe the steps for percutaneous cannulation, anticipate, recognize, and manage cannula-related problems. That's the primary goal from ECMO. I think you hear that from Polito. That's for the case of cardiac ECMO, you would like to restore the circulation. Patient in multiple pressures, inotropes, blood pressure is low. You would like to restore the circulation again with the ECMO to reduce the high doses of pressure to allow the heart to recover and also perfuse the end organs with blood again. In case of PV ECMO, we would like to secure the oxygenation again and rest the lung and buy more time to treat the underlying disease. And there's a basic cannulation configuration here. If you look to the profile A, you see that's a patient with PV ECMO. It's a dual side cannulation from the right IJ to the femoral, and I'm going to talk about that later on in my presentation. In the tiles, let's focus now on PV ECMO. You see the profile in the figure B. That's the fem bypass. We're getting blood from the femoral from the femoral vein and returning the blood back to the descending to the iliofemoral artery or descending aorta. The C is not for us now for more pediatrics, that's when you can read the carotid, that's really different topic, and taking longer time to talk about that. And the D, that's the central cannulation, which you bring to take blood from the right atrium and return it the blood back to the descending aorta. That was open chest. I'm going to talk about that later. Now, central cannulation is performed in operating room that we have to have open chest, usually trained by CT surgeons after post-cardiothomy conditioning shock, patient had a cardiac surgery and have difficult weaning from bypass. And despite inotrope optimizing all of the conditions the patient have, you are not able to separate the patient from cardiopulmonary bypass to decide because the patient will be an ECMO in the operating room. You can read the right atrium and cannulating the aorta and start the ECMO circulation. And the advantage of the central cannulation here, you can use bigger cannula. You can use the big cannula up to 46 venous cannula is right atrium. You can and use also bigger cannula in the aorta that you can, with the bigger cannula, you will be able to have more flow. That you can get 6 liters, 7 liter flow based on the pump you are using. It's also one of the advantage we having central cannulation. You have an antegrade antegrade flow. That means like in a physiology. Blood comes from the heart and going and support all the organs because you are cannulating the aorta, the blood taking the physiologic way from the aorta and supporting all organs. In peripheral cannulation, I'm going to show you later on my presentation, is we're calling that retrograde perfusion, which is might have some problems and straightforward. The problems we have with the central cannulation, you have to open the chest. It takes some time to open the chest and cannulate the patient. Also, risk of infection or bleeding is high compared to the peripheral and percutaneous cannulations. That's why we moved in early days, it was central cannulation. Now we moved from many years to do peripheral cannulation and limit the central cannulation for post-cardiothomy cardiogenic shock patient in the operating room. That's the peripheral cannulation. When you talk about that, I limit the talk today because of the time to the fem bypass. When we go to the groin and cannulate the femoral artery and femoral vein and put 2 cannulas. The first cannula, the venous cannula, is going to go to the right atrium and taking blood from the right atrium and returning the blood back again to the femoral iliofemoral artery, and that's the blood now will come from the femoral artery and in a retrograde way supporting the. I have some cannulas here, and that's a cannula will be placed in a from the femoral vein going to the right atrium, and that's the arterial cannula will be placed in below the bifurcation, after the bifurcation, and the blood comes from here and supports it towards organ. We call that retrograde perfusion. Problem with that means more like because of the size of the cannula, it depends on the size of the, before you're going to place the patient on the ECMO, you have to look at the size of the vein and the size of the vessels, utilizing ultrasound techniques to help you, to guide you, utilize the size of the cannula and also look at the size of the patient and anticipating the flows the patient is requiring. It's easy to be deployed, could be done here in this room, and we have a mobile unit we are traveling everywhere and cannulating the patient outside the hospital, outside the ICUs, and with everything we have in two big suitcases, we can apply that anywhere. And there's a group in Paris, they applied that probably so that in the news, they applied that even in a metro station in Paris with their mobile unit. The problem with that's maybe is this cannula here putting 17 or 19 French cannula as a femoral vein, femoral artery might lead to ischemia to the lower limb, might prevent or lower the blood supply to the lower. To overcome that, before we are going to see that later on, before we are placing this cannula, we are placing the antegrade cannula in the femoral artery in SFA to selectively perfuse the lower limb. We're taking blood from here and bypassing the stenosis and perfusing the lower limb. That's the cannula we are using. That's here, and you guys can hands on, everybody can see that. And the insertion steps here, you're going to see that. That's here. That's here. Everybody of the team member will be doing that in the ICU. We have certain steps, and everybody has certain role from the team to make it in an organized way and not in a chaotic way, and to have smooth cannulation and prevent complication. That here at the bedside cannulation, you see the patient will be scrubbed and prepped in a routine way, and both groins are here covered. And we're starting now with the antegrade cannula. Why we start with that? Because if I start to cannulate with the big cannula here, it's tough to identify the vessel, the SFA, after placing the big cannula here. That's why I'm starting first with identifying the SFA and placing my 5 to 7 French cannula in the SFA before I'm placing the big cannula in the femoral artery. This is the technique. As you see here, we started to cannulate the SFA in an antegrade way. And then after that, you're going to, with using also ultrasound, identify the femoral artery, common femoral, and also puncture it and place the wire and introduce the wire. After placing the wire, you start with the dilation up to one step. We can dilate one step before below the level, before the size of the cannula you're using. If you're using 17, you go dilate to 16. If you're using 19, you dilate to 18 French, and then place the cannula to prevent bleeding later on. And when you get that done, and you see the cannula here in a arterial cannula in place, and you go to the other side and place the venous cannula in the same way, and then you have with connectors. That means you place the ECMO cannula at the ECMO set, which was prepared before we started cannulation, and the ECMO coordinator will bring the system to the field, and in the right way you're going to connect. That means to T-air, because if we have to connect the ECMO circuit with the cannula, there's some air will be collected here. We have to de-air this area, and we put that word connected to the air organization. That here they are connected, and you're going to unclamp and start with the circulation, and you're going to see here's the difference. Here's the color between the arterial side and the venous side. You're taking blood here from this cannula and returning the blood back here to the femoral artery. That's here. After the cannulation, we see that here that's airflow cannula, outflow cannula, and here the shunt and the retrograde perfusion. The antegrade perfusion cannula will be placed to perfuse the lower limb. And after that, you do an imaging to be sure that everything in the right place. As you see, that's the cannula is in position here, just below the diaphragm, or sometimes we're placing that in the right atrium, and that's here the arterial outflow cannula, the short cannula we use for the retrograde. That's here the lower limb perfusion cannula. We're using sizes between 5 French. That's here the small one here, 5 to 7 French. And after replacing this cannula, we're doing arteriogram at this site to be sure that the cannula in an SFA that you see here, that's the cannula here, and they nicely perfuse the SFA and perfusing the lower limb. That's here to prevent the ischemia. Now with the veno-venous cannulation, we have different configuration for the veno-venous ECMO. We have dual side by lateral femoral veins. We take blood from the femoral vein below the diaphragm and returning the blood back again in through the longer cannula to the right atrium. That's here is have the advantage that you don't need imaging, you can do that as a bedside without always what you need is ultrasound and easy to implant, but the flow will be limited. And we have the femoral vein and internal jugular, giving you more flow, and risk of recirculation is less than with the bilateral femoral veins. You are cannulating the internal jugular and you're cannulating the femoral vein and placing the outflow cannula in a superior vena cava, and you're taking blood here from just below the diaphragm. Blood will come from here going to the pump and returning back to the superior vena cava. And we have the very smart way now to do PV ECMO, which is the one single site cannulation, which is the that's the cannula here. We call that aggressive cannula, with one with internal jugular will be placed like for the internal jugular, with the tip here will be placed in the inferior vena cava. You have inflow port here and inflow port from the inferior. You're taking blood from the inferior vena cava and superior vena cava, and you're returning the blood back through this holes here to in the right atrium. And from the right atrium, the blood will be going from the right atrium going to the tricuspid valve, from tricuspid valve, right ventricle, and to the pulmonary artery. In this way, you are preventing recirculation. All the cannula is in the venous system, and one of the problems we have with the venous with the EV, that's the high rates of free circulation. With this way, with the crescent, you've got the crescent and or protector and the Avalon cannula, we are able to reduce the recirculation and improve the performance of the cannula. That's one way of doing single site cannulation. There's other way of performing single site cannulation, so the OCR pads, which are going to place cannula also from right IJ, going to the right atrium, from the right atrium to the right ventricle, from the right ventricle going to the pulmonary artery. You're taking blood from the right atrium and taking blood from the right ventricle and returning the blood back in a pulmonary artery. That's here having a valve in between the inflow and outflow will prevent the recirculation. But it's more demanding in placing this cannula. This certainly needs bronchoscopy to be able to do that. But with that method here, you can give the patient 5-6 liters of oxygenated blood with lower risk of recirculation. Let's see. That's here. You see that's dual site cannulation. How is the cannula located? You see that's the right IJ cannula, and that's the inferior vena cava cannula. You see that here we usually try to keep 6 to 8 centimeter distance between the inflow and outflow to prevent the recirculation, because you're sucking blood from here and returning the blood from here. If these two cannula close to each other, you're having a recirculation of blood and the performance will go down. And that's here the single site cannulation as I described to you. And that's the way we are doing that here. And you see that's the cannula here, that's the Avalon cannula going from the right IJ, right superior vena cava, right atrium, and going ending in an inferior vena cava. And we sucking blood from here, and returning the blood back here in right atrium. But that way, we also prevent recirculation. Here, that's here spectrum catheter, which is here for the right IJ to the pulmonary artery. We're taking blood from the right atrium, right ventricle, and returning the blood back here in the pulmonary artery. That's here after cannulation. We try to have imaging to confirm the position of the cannula. That's here an ultrasound when we're placing the Avalon catheter. Have to do ultrasound after that to confirm that the tip of the catheter here is about 6-7 centimeters in the hepatic IVC. Why are we doing that? Because if it's too deep, you might also increase the recirculation. It's too shallow, will also also increase the rates of recirculation. And we're doing that with ultrasound at the bedside. We measure the distance from the catheter tip to the right atrium here, and should be here. The base of the catheter type you are using are 7 to 9 centimeter. And also trying to confirm that the flow, the outflow port is in the right atrium, and you can see that here with the flow Doppler, with the color Doppler, to see that nice flow in the right atrium going towards the tricuspid valve. When we part now after the cannulation and manage the patient, also we have to pay attention to ECMO is not for long-term treatment. ECMO is short-term treatment, and most of the patients we have to wean them. We're bridging them to recovery, and most of the patients either going to be weaned or go for durable support or lung transplant, and some other patients unfortunately will die. But we have to know that we pay attention now to the weaning process and weaning protocols that we publish our data on that protocol. We have extensive experience on that. Probably because of time, I will not go with the weaning process and what's criteria to wean patient from EA or BB ECMO. And also that's here list of the complication what might happen after placing the patient on ECMO, and that's the list from our complication. We published that in the Annals of Thoracic Surgery 2019 from our experience in Davis, more than 180 patients, and most all categories of complication we have less complication rate. If you lose the bleeding here, that was our experience in Integris. We have 22%, whereas in the literature you see between 29 to 30%. If you look to the hemolysis rate, was also lower in our cases compared to the literature. Neurological complication was also lower. Why I'm presenting that here? Because what we did and what we're doing in San Francisco, we are training intensivists to cannulate VB and VA. Most 90% from ECMO programs are done by CT surgeon. And we started that in Hershey, Penn State, Hershey Medical Center, to try the intensivists to do that with success, and Integris with success also in San Francisco was a great success. And if you look to your complications and compare that with what's published, even with intensivists run model, we have lower complication rate and good outcome. And why I'm saying that? Because it's making ECMO available and accessible. If you're waiting for CT surgery, cannulate, usually they are tight in operating room, but if you train more people to do that and do that in an appropriate way, you open the door for the technology, which is helping more patients. That's here we have to, as I mentioned before, is lower limb ischemia, one of the major problems we have with this patient, and to monitor the lower limb oxygenation, we're doing every patient infrared spectroscopy and looking to see saturation in the leg, and we compare the cannulated leg versus the not cannulated leg to see if something happened, you have to intervene early. Also, we are doing an arteriogram at the bedside to confirm the position with the antegrade cannula. As you see in SLA, is in the profunda, and that's which shouldn't be in the profunda, and here was unfortunately was placed in an esophagus vein. That's here one of the problems we might have. Also the which is called the Harlequin syndrome, which is having if the cannulating peripheral patient with peripheral ECMO, we're going to have two circulations. If this heart stops to eject blood, you're going to have two circulations. And these two circulations now is going to meet at one point in our either ascending descendants based on how much ECMO flow you have and how much blood you're getting from the heart. Here in this case here, you see that's the interestingly that you see the left carotid is and the right carotid here is for right carotid is perfused from the blood coming from the heart, and the left carotid perfused from the blood coming from the heart. In case you have patient now with a good heart and bad lung, the blood coming from the heart will be less oxygenated, and you might have some oxygenation problems to the brain or the heart as well. That's why we always in the ECMO patient will try to get blood gathered from the right radial artery to be sure that the perfusion to the brain and other organs are okay. One of the other complications with having is aortic thrombosis and left ventricular clots. That if you draining a lot of blood from the heart and the heart is too weak and not ejecting, you might have stagnation of blood in the aortic ventricle and you might see clots here. Also, one of the complications might have cannula dislodgement, as you see here, the cannula immigrated from the right atrium here to the right ventricle. And here also some technical aspects with under CPR, we cannulate the patient here and while having an filter, IVC filter, and we went through the, that's something that you have to, that's just also some patient here is having, it might happen if you don't have enough heparin, the oxygenator might clot, and you have to be attention to that. Also, that's my last slide here, you see that we pay attention to this patient while they are in ECMO. That's why we try to also select our cannulation to help us to appraise the patient here. That's the patient with peripheral PA active. It's not central, it's not axillary, it's peripheral PA active. We started to appraise this patient to be able to do steps like the gentleman here. That's the patient with PA also able to operate out of it and to all that because that would help the patient to recover. Yes, in the left side, that patient was waiting for to get an LVAD, and that's improving the outcome. Patient recover, all organs are recovered, and patient able to operate, as also opening the door for the patient to convince the team to accept this patient for advanced therapy. I'm not going to stop here, and if you have any question, we're more than happy to do that. And if you need more to know about that, we're more than happy to come back and to tell you more about this. We have many stories and many patients, but because of time, I was not able to put all that together. Thank you very much for your attention. Quick question, because I like to keep some time for it. That's the cannulas here, or somebody wants to come and see it.
Just X out.
Should be.
So as you see, ECMO can become quite complex, and the ongoing management of patients on ECMO is where complexities really tend to arise. So we'll close things out here talking about some high-level concepts relating to physiology. These play a role in our patient selection, so it's important to understand. So the reality is as complex as all this is, the machine is fairly simple. It's ultimately a pump with a gas exchange device attached to it. And in order to support your patient, you need to achieve flow with that pump. And when it comes to the machine itself, all you can really do is turn up the RPMs, right? But the effective flow that you're able to deliver to a patient is dependent upon other factors, particularly the preload and the afterload that pump is encountering. And so when it comes to managing patients on ECMO, we are continually working on the interaction between the patient and the machine. And you have to be able to balance those interactions in order to achieve the support that you're desiring with this treatment modality. So the preload is dependent upon things that, the native circulation depends on as well, like blood volume, vascular resistance, but it also incorporates the resistance with the circuit as well. And often the venous drainage cannula is a component that will ultimately limit how much flow the machine can achieve. Also, intrathoracic or intra-abdominal pressures, so putting extrinsic pressure on that cannula will affect how well you're able to flow. Even something as simple as coughing can cause issues with preload to the point the pump cannot function. Same principles apply on the back end, on the afterload side, right? The arterial cannula resistance, usually less of an issue, because as Dr. Baniosi showed you, they're shorter, smaller cannulas. The membrane lung, as he showed you in the picture earlier, can form clots and degrade with time, and you can encounter higher resistance there. When it comes to VA ECMO, the patient's systemic vascular resistance, or their MAP, is effective afterload to the ECMO pump. So you have to balance their blood pressure with pump flow in order to achieve appropriate levels of support. So these machines, they're preload sensitive and they're afterload limited. And this is important from the initial moment of cannulation. So if you're somebody that's referring, or if you called for an ECMO consultation, preparing blood products and having the ability to mitigate these right up front is critically important. So here's you saw some pictures of console screens earlier. Here's one up in the top left corner. You can see that this patient is supported with about 4 liters of ECMO flow. For sake of time, we'll say all the other pressures and numbers are appropriate. And you can look and see that there's a pressure sensor on the venous drainage cannula. You're at negative 44 millimeters of mercury, so not a lot of negative pressure with the suction from that drainage cannula. But what happens is this patient coughs. You'll see a spike in that pressure, and you'll see that it adversely affects flow. So you'll drop your flow from 4 liters down to roughly 1.5 liters. And so that's going to cause an issue if the patient's constantly coughing. If you extrapolate that to a continual issue, you realize that you can't deliver support to the patient. You're not mitigating the interaction between the patient and machine. Here's a more extreme example. So you can actually look and you can see this venous drainage cannula is chattering or shaking. So there's constant variable negative pressure on this machine due to an issue with preload. And as a result, ultimately, you're not delivering support adequately to that patient. So these concepts apply whether you're on VB or VA ECMO, and they're constant challenges. It's just to stress the point that the ongoing management requires a constant balance between the patient and the machine. So breaking it down a bit further, there are some unique challenges to VB and VA. So here's a patient on VB. We'll take it that this patient has severe respiratory failure, say ARDS, is failing mechanical ventilation, as Dr. Polito mentioned earlier, unable to do it safely, requiring excessive pressures that are injurious to the lung. So they're placed on ECMO support. And if you look at the top left corner, you'll see they're receiving about 3 liters of ECMO support. And for sake of time, all the pressures and everything else is in adequate range. But if you look down, there's a sensor that measures the oxygen saturation on this particular console in the venous drainage cannula. For some people will call this an SVDO2, a venous drainage saturation. You can think of it like a central venous oxygen saturation. What's in the veins is being sucked into the circuit. In this case, has a low saturation. So you know that there's some mismatch between oxygen delivery and oxygen consumption for this patient. And that's manifested over here in hypoxemia on their arterial oxygen saturation. Now they're on pretty minimal vent settings. And the question becomes, how do you balance machine versus patient to improve their oxygenation? You can either do it with the ventilator or you can do it with the machine. And as mentioned earlier, ideally in scenarios like this, you're going to try and do it with the machine so you can rest the lungs and give them the opportunity to heal. So the important concept, with VB ECMO is that you have these 2 different circulations, that they're functioning in series. So you have blood in the venous system, some of that blood is taken in to the ECMO circuit, some of that blood bypasses the ECMO circuit, returns to the right side of the heart, and goes through the native circulation as it normally would. That blood going through the native circulation, however, is not receiving good gas exchange. It's effectively shunting across the lungs because the lungs were injured and they're not functioning. And so if you want to improve your arterial oxygen saturation, you don't do it through the ventilator. You have to do it by increasing the proportion of ECMO blood that's in this 2 series in circulation, or 2 circulations in series. So the point here is that you need to increase your flow on the ECMO circuit. You need a higher relative ECMO flow to cardiac output to support this type of patient. And for example, a patient who has pretty severe lung injury, whose lungs are barely or even not functioning, we're talking in the realm of maybe 70% of their cardiac output needs to be matched by ECMO flow. So if you have 5 liters of cardiac output for your patient, that patient's going to need 3.5 liters of ECMO flow in order to achieve appropriate oxygenation in their blood. So blood flow in VV ECMO equates to oxygenation. More blood flow, more oxygenation. There's pitfalls with that. As Dr. Beniosi showed you, we have dual or single side cannulas where both the inflow and the outflow go into the same cannula. Well, that means that overall lumen size is split between the drainage component and return component. So that's going to limit how much flow you can place through that type of cannula. Some programs do the dual side, so they'll have the drainage in the groin, maybe the return in the right IJ. That allows you to get 2 cannulas in, larger overall diameter, and the ability to flow more in certain circumstances. But there's a downside to that, and that is sometimes you have your flow. Ideally, the ECMO return goes into the RV and through the lungs and provides the support you want. If you're in a situation where you start increasing that flow too much, it may be too fast for the blood to entrain into the RV. It may simply bypass and go right back into your drainage cannula. So you end up with recirculation. So it's a tough situation, right? You're trying to go up on flow to increase support, but the higher you go, the worse the patient gets. So here's an example of that. You see the return cannula, and you see the drainage cannula, and they're too close together. They're overlapping here, right? And that's manifesting with a low oxygen saturation. And if you look at that sensor on the venous return, the drainage cannula side of the ECMO circuit, the saturation is very high because you're simply re-entraining and you now split those circulations apart. And if you look, often you'll see the cannulas, the color change is no longer there. They're both bright red because of both oxygen and blood. So the point is there are unique challenges depending on cannula configuration that have to be continually mitigated and balanced. So there are some limitations to how much support you can provide to patients. All right. So the VA side has its own unique pitfalls and pearls. So here's another patient example. This patient's on VA ECMO for cardiogenic shock, right? You can see they're on quite a bit of medical support. They're on a pharmacologic support. They're on a pressor, an inotrope, an inopressor, pretty respectable doses. They still have inadequate perfusion, right? They have a MAP in the 50s. They have very poor pulsatility, so the native part's not doing a lot. And they're receiving ECMO support. So if you look at the top left, they're receiving about 3 liters of ECMO flow. And because this is returning to the arterial side, that 3 liters is an addition to their cardiac output. Right? You're supporting the cardiac output and potentially the lungs as well, depending on the circumstances with VA ECMO. For sake of time, everything else here is fine pressure-wise. But if you look, that venous drainage saturation, again, is low. So this patient has a mismatch between oxygen delivery and oxygen consumption. So the question is, what balance should we strike for this patient in order to achieve appropriate perfusion and appropriate support? And it's almost as simple as any patient you're mentioning, right? Your mean arterial pressure, your perfusion is dependent upon how much flow you're delivering. Typically, it's just your cardiac output. But here, it's cardiac output and your ECMO flow, which are additive. But in some ways, they compete with one another, which we'll see on the next slide. You have your systemic vascular resistance, which you can take up or down from pharmacologic therapy. And you have your preload, which you can increase or you can decrease with volume and diuretics or renal replacement therapy. So your total systemic blood flow is a combination of these two. But one blood flow from the native cardiac output is going antegrade down the aorta. If you're using peripheral ECMO, that blood flow is going the opposite direction. It's going retrograde up the aorta, and at some point, these two collide and you have a mixing point. If that mixing point is up near the heart, there's some pros and cons to it. That means that this heart is very weak, it's not ejecting well, and you're pretty much fully dependent upon ECMO flow. There's some benefits to that. You're ensuring that all the blood getting up to every branch of the aorta, and importantly up to the brain, is well oxygenated from the ECMO circuit. There's a downside to it though, and that is if your heart has poor pulsatility, it's not squeezing well, it's not ejecting, you're going to run into issues. And that ECMO flow is pushing against the heart, and it's going to increase your end diastolic pressure in the LV, and it's going to dilate that LV, and that can precipitate worsening failure. As Dr. Baniosi mentioned it earlier, there's also a catastrophic complication where you can end up with a large thrombus in this LV as a result of this. So you have to balance the flow between these two. You need enough movement out of the left ventricle that the heart can recover and is not further damaged by the circuit. You also need to ensure that you're providing adequate perfusion, well oxygenated blood to all parts of the body. So you kind of aim for a balance between these two, basically. And the point here is that unlike VV ECMO, where you have two circulations in series, these two circulations are now parallel with VA ECMO. And they do combine, but that combination has some competitive aspects to it. This becomes even more important if they have concomitant pulmonary injury as well. So take a patient, severe ARDS, has a PA arrest event, has a stunned myocardium, component of cardiogenic shock. Let's say you put that person on VA ECMO, a few days later, their heart starts to recover, their EF is, gone from nothing to something, essentially. You've been able to down titrate your pharmacologic support to the heart. And so you're making progress, but you face another issue now. You're starting to see worsening saturation in the arterial system. And that's because of where these mixing clouds occur. So if you're considering now that everything coming from the heart is dependent on the lungs for oxygenation. So if those lungs are not functioning, now everything coming from the heart is poorly oxygenated blood. And so you end up, depending on where your mixing cloud is, as the heart recovers and that mixing cloud moves down, now the initial branches, the aorta, are receiving deoxygenated blood. And that's important because that's what's perfusing our brain. So as Dr. Baniosi mentioned earlier, we're always checking gases and pulse ox in the right upper extremity so that we ensure that we're not resulting in low oxygenation or overly high carbon dioxide levels to the brains. So this has taken many names over the years. Kind of what's been adopted most recently is like differential oxygenation to distinguish that there is an oxygen component and a CO2 component to this. And there's an acid-base component. What the brain is seeing, what the kidneys are seeing are different. So as we're managing these patients going forward, we're always considering this day to day in our management. And the point I'll make with that is the ECMO configuration may evolve as the patient's pathophysiology evolves. So as mentioned earlier, there are some hybrid modes. This might be a situation where as that patient's heart recovers, we convert to a hybrid mode. We add an additional venous cannula, so we're putting some blood upstream of the heart and downstream. We could change where the cannulas are located. The point is we're not married to the initial ECMO configuration that we place the patient on. So as their physiology evolves, our treatment can evolve as well too. There's a long list of other complications as you've seen, but with that, stop time taking the additional questions. Thanks everyone.
We're actually done, so if you all have any questions or anything, feel free to ask. Oh, your phone's.
Okay, yes.
I'm trying to thank.
Sorry. Yes. We are listening, but it gets there. At a house. Like so much, they go more now. We don't like the rush trial.